A new screening programme for families at risk of heart disease linked to high cholesterol has been operating in the Southern Trust since April of last year. And to talk a little bit more about this, I'm joined by Dr. Peter Sharp, who is a cholesterol and diabetes consultant with a much, much more elaborate title than that. But I think that's about the simplest way to put it, Dr. Sharp. And we also have nurse Julie McCullough, specialist nurse Julie McCullough in the studio. If I can just start with yourself, Dr. Sharp. Tell us a little bit about the programme that's operating within the Southern Trust at the moment.
Okay, so the programme is to screen for a condition known as familial hypercholesterolemia, which is abbreviated to FH, which is a lot simpler way of looking at it. FH is a condition that occurs in about 1 in 500 of the population and is associated with high cholesterol levels, generally over 7.5, often over 8. And of course there are many other causes of high cholesterol. FH is just one, and it's actually quite a rare cause. But this condition is associated with a very high incidence of ischemic heart disease or coronary disease. It tends to occur at an early age in families, so generally below the age of 60 and often below the age of 50. So what we're trying to identify is folk in the population who have high cholesterol levels, generally over 7.5, and have a strong family history of early onset heart disease.
So it's really about genetics and whether there's a history of it in your family already. We're not talking about if you have a high cholesterol as a result of your lifestyle.
That's correct. I mean, high cholesterol
might have
high
just
cholesterol
after Christmas.
It's very common in our population in general, and much of it is linked to our poor diet, lifestyle, being overweight. Perhaps if you have diabetes, you're more prone to it. If you have an underactive thyroid, if you have protein in the urine, all of those will be looked at by your own family doctor if you get a cholesterol level checked. But this is a particular condition affecting about 1 in 500 of the population. So we reckon that within Northern Ireland there's about 3,500 individuals with familial hypercholesterolemia.
How many of them know that they have it?
Well, so far we've picked up 1,000 approximately in Northern Ireland. You introduced me as working in the Southern Trust, and that's correct. I look at all of the cholesterol patients within the Southern Trust, but the same service has been set up in the other 4 trusts in Northern Ireland. So there are specialist lipid clinics with similar nurses to Julie that have been appointed in all of the 5 trusts. And the idea is to try and identify the 2,500 individuals that still need to be identified within Northern Ireland that we don't know about. So what I'm saying is that if you get your cholesterol level checked and it's above 7.5, 7.5, and you do have that strong family history of early onset heart disease, coronary disease occurring in your family, that would be your mother, father, brothers, sisters, grandparents below the age of 60, but particularly if it's below the age of 50, that would set alarm bells ringing that you may have this condition. And what we would want people to do is, first of all, go to their GP, get their cholesterol levels checked, identify what the cause might be, because there are many other causes other than this condition that can be easily treated. And then if the GP is suspicious that you could have this condition, then you would be referred into our specialist lipid clinic, and then we would be organising genetic testing. And genetic testing is available in Northern Ireland for FH. The Regional Genetics Laboratory is an excellent laboratory established in Belfast City Hospital that is able to offer the full range of genetic screening for this condition. So we find that there's about 40 common genetic defects that can cause this condition within Northern Ireland. That accounts for about 70% of the total, and then there's several hundred other rarer varieties that can also be screened for. So we're fairly confident that if you have this condition and you get the genetic test done, we can pick up the particular defect, as it were, within the gene that's causing that. So
you need a GP referral, first of all. If we can just bring in Julie. Julie McCullough is a specialist nurse working with the family testing programme. Now, Northern Ireland is one of the first countries to introduce the family testing programme. Talk to me about the risks associated with this condition, Julie.
Well, the risks are the same as with any high cholesterol, really. The risks really is that you could end up having a heart attack or a stroke, even in your 20s or your 30s or your 40s if you have this condition. But the benefit is when we diagnose you, that is easily managed. You just take a medication. For example, it's a statin. So you're reviewed by the consultant at the clinic and he will review your medication. Now, there's a lot of publicity and press, bad usually, about statins, and they're the side effects of them. But there aren't just one statin, there's about 4 or 5. There's a variety of different ones. So one might not agree with you. The benefit is that you're seen by the consultant, and you also have a follow-up and a contact with myself or one of my nursing colleagues, and they can follow you up and see how you finding the statins. Is it okay for you? Do we need to change it? Do you want me to liaise with the consultant? We'll see what fits best for you. So it's trying to tailor the medicine to fit the person.
And this is really for people, as I said before, this is for people that just haven't a raised cholesterol as a result of a lifestyle. This is genetic. This is inherited, really.
Yeah. I mean, obviously, fitness campaign, trying to lose weight and motivate yourself and exercise will help your cholesterol. That will do it for everybody in the population. And the Public Health Agency, who actually fund this programme, has a big push on at the minute to try and motivate all of us to try and reduce our waist size, increase our fruit and vegetables to 5 a day. So that general information, no matter what condition you have, goes out to everyone, and the same with people with FH.
And what about ages? Because it says family testing programme. So do you test everybody in a family that may be at risk?
So if you present to your GP and you're referred to Dr. Sharp or any of the other consultants in the Lipids Clinic, the genetic test initial can take about 9 months to come back. It takes a lot of work to find out what that gene is that's incorrect in you. If it turns out that you're positive for that gene, because it's genetic, there's a 50% chance that you can pass it on to your children, and you have inherited either from your mum or from your dad. If you do have the condition, then that's where the consultant will pass you over to the specialist nurse. We'll have a wee bit of a chat about your family, and I'll take some details: brothers, sisters, mum, dad, cousins, children, and then we'll work our way through and offer that genetic test into each one of them.
And what about children being at risk, Dr. Sharp? What are the risks of a child having high cholesterol?
Well, if they have this particular condition, familial hypercholesterolemia, children, if they have inherited that from the parent, and there's a 1 in 2 risk that they have done so, they can have a high cholesterol level right from a very early age. Now, we normally do the screening for the genetics the beginning of the P1, so we leave it really to primary school age and often to the age of 9 or 10. But there is increasing evidence that some children from about the age of 10 onwards, and that would be boys in particular who are more at risk, may require cholesterol-lowering tablets. And that's often difficult to persuade the parents, who will often ask, of course, is there benefit for my child in taking a medication, which would be lifelong medication? But we believe that there is good evidence that can often prevent complications such as heart disease occurring later on in life. So sometimes we do treat boys from maybe the age of 9 or 10 if they are very high risk. In other words, if they have parents or relatives who have maybe had heart disease, heart attacks in their 20s and 30s, for instance. I think there's good evidence there. With girls, we tend to leave it a little bit later. The evidence is a little bit unclear, so we are very cautious about treating children. We monitor them very carefully, but increasingly so we like to pick up children at an early age, because the evidence would show that furring up of the arteries, hardening of the arteries often begins in this condition around the age of 10, 11, 12, and maybe before that. So we would suggest that treatment to lower cholesterol, which is a very effective treatment for this condition, will prevent the complications occurring. So
if you're concerned, then go to your GP and as simple as get your cholesterol checked.
Yes, I mean, this is a good news story. I mean, it is a genetic condition. People, when they hear the word genetic, think this is a life-threatening condition. And in the past it was, because if the condition remains untreated and unidentified, half of men will have had a heart attack before the age of 50, half of women before the age of 60. And then another further half of those men will have died before the age of 60, and in women before the age of 70, due to the very high incidence of heart attack in particular.
So early detection is the key.
And we now know that giving readily available tablets, again known as statins, these are effective cholesterol-lowering tablets. By lowering your cholesterol, you can lower that risk of heart disease very significantly. In fact, almost the same level as an individual who does not have this condition. So in the past, while life expectancy was vastly reduced, nowadays it's almost identical to an individual who doesn't have the condition, as long as it's effectively treated. So we recommend the earlier detection, the better. You don't want to leave it until your 30s or 40s or 50s before identifying this, when perhaps you're presenting with a heart attack. You want to pick it up at an early age. And then when you've identified that in a family, we do this so-called cascade family screening, which is just a fancy term for really what Julie has already described. We've picked up the defective or abnormal gene in the family, and then we can go and screen the children and the other relatives and pick up whether they have this condition, and then offer them very effective treatment. And can I just say that statin treatment does get a lot of bad press, but the evidence base for statins and lowering cholesterol is overwhelming. It's overwhelmingly positive that we can effectively prevent complications, ischemic heart disease and stroke later on in life by using these tablets. People are worried about the side effects. These tend to be very minimal. Sometimes folk will get aching muscles in their arms and legs. We can often try another statin. There are other treatments that we can add in on top of the statin, and in some cases we have alternatives to statins, but we do recommend a statin treatment because that's where the evidence base is.
Early detection and treatment is there. Now, it would be remiss of me today, in a day when further pressures are on our emergency departments and trusts are cancelling non-urgent elective surgery, to not ask you if something like the family testing programme is at risk of being shafted, really.
No, I don't think that's going to happen at all. And the reason I state this is, we are being overwhelmed by admissions to hospitals and pressures, certainly. But we believe that offering screening programs, early detection, early intervention that can actually prevent these complications occurring in the first place will free up resources in secondary care. So in other words, if we treat these patients, screen them, offer them dietary and lifestyle advice, give them effective treatment, you can prevent the heart attack occurring, you can prevent the hospital admission. And this isn't just for the area of familial hypercholesterolemia, but generally we want to try and ask and plead with our population to try and take lifestyle choices and make their own personal decisions that will impact on improving their general health, which will then in the future avoid them having to be admitted to the A&E department or the ED department. So screening and intervention, lifestyle choices, improving your diet, improving your lifestyle, losing weight, all of this will improve your life expectancy, it will improve your general health, and it will mean that you won't be queuing up at the door of the emergency department until maybe later on in life. Anyway, we're all going to be there eventually, I guess, but you can certainly do a lot yourself to try and prevent many of these diseases happening.
Indeed. I know in the Southern Trust has cancelled less than 10 operations and is doing so, was doing so yesterday. Only. That was the latest that I had from yesterday, just as it cancelled 10 and that least affected. But what are your thoughts on the cancellations and the state of our emergency departments at the moment, Dr. Sharp?
Well, I'm probably not the best person to be asking about that. That's not where my area of expertise or management lies. So I'm reluctant to make anything more than just a personal observation on that. I mean, I think that, this reflects our generally ageing population, the fact that people are living longer now with chronic diseases. We have many elderly people living on several years longer, even compared to 10 or 20 years ago. Many of them have multiple disease processes and have a lot of ill health ongoing, and they're obviously going to be in and out of hospitals from time to time. And of course, at this time of the year, during the winter, there's always the pressures of increasing admissions to hospitals, which is going to impact on folk undergoing elective surgery and elective procedures. And of course, we always try to minimise that as much as possible, but there is a finite resource there. There's a financial difficulty in the health service, as everybody is very familiar with. There's pressures on beds. Beds have been reduced. And at times there will become pressures that really just explode and become overwhelming. And during those times, it's important that we deal with the urgent cases. And unfortunately, some folk who are undergoing elective or routine procedures, they will simply have to be delayed or cancelled. It's not ideal, but we don't have a funding source that's going to cope with everything in the NHS. We have to obviously just deal with the impact at a particular time, and this is a particularly difficult time of the year. It always has been, and I guess always will be.
Dr. Peter Sharp and Nurse Julie McCullough, thanks ever so much for joining us in the studio. If anybody wants to find out anything more about the family testing programme, Julie, where can they go?
They can go to their GP and speak with them. I think just to stress to people that it isn't very common. I would think if you visualise going to Ravenhill to see a rugby match, there's about 18,000 people. In that 18,000 people, 36 people will have this. But if you're one of that 36, we can do something to help you. So give your GP a wee ring.
That puts it in perspective. Thanks ever so much for joining us on Daytime.
Thank you.